Good afternoon, esteemed colleagues, and thank you for gathering here today on World Cancer Week. This week stands as a global reminder of the importance of cancer awareness, prevention, and research. As we reflect on the ongoing fight against cancer, we also acknowledge the growing body of evidence surrounding the intersection of oncology and other health challenges, one of the most significant being the influenza disease. But before we discuss more on the topic and I introduce you with our esteemed speaker, I, Dr. Trambak, Senior Medical Advisor, Zydus Vaccines, welcome once again all of you to this session, and I will discuss with you in short today's agenda. So initially, the welcome address, the agenda discussion, Zydus overview, and a brief context setting by myself, then followed by today's session, a role of annual influenza vaccination in oncology, safeguarding patients and enhancing treatment outcomes by your esteemed speaker, Dr. Nitin Shah, followed by a short question and answer session and thank you note. So I will be beginning on the Zydus corporate overview. As you all would know, that Zydus is a well-integrated pharma player with a proven track record, with over 23,000 people impacting lives across 4 continents in this world. We have around 300 plus generic products, 20 plus active drug discovery programs with more than 1,400 research scientists working day in and out. Launching products that address unmet healthcare needs such as Lepaglyn, which is India's first NCE to treat diabetic dyslipidemia, Exemptia, the world's first biosimilar of adalimumab, Vacciflu 4, which is India's first quadrivalent influenza vaccine, Twinrab, world's first novel cocktail of 2 monoclonal antibodies in rabies post-exposure prophylaxis, Bilipsa, the world's first drug to get regulatory approval for NAFLD and NASH anywhere in the world again, ZyCoV-D, world's first plasmid DNA vaccine for COVID-19, Oxemia, a breakthrough treatment for patients suffering from CKD in India. A very brief on Zydus Vaccines. Zydus Vaccines acquired Aetna Biotech, and it worked in collaboration to form these following centers, which is the inactivated influenza vaccine and the inactivated center for vaccines, the live viral center, the bacterial center, or the vaccine technology center, the recombinant VTC, and the biological unit. So if you see the journey of Zydus Vaccines, we started back in 1990. To 2000, we launched the Vaxirab-N, and before that, the typhoid and the Hep B. We acquired Aetna Biotech in 2008. 2010, we launched the Vaxiflu S, which is the monovalent H1N1 vaccine. Vaxiflu 4, India's first quadrivalent inactivated influenza vaccine in 2015, followed by a full-fledged division, the Vaxicare division. Zyvac TCV, the launch of indigenously developed typhoid conjugate vaccine, which is now WHO pre-qualified, followed by Twinrab, which is, as I discussed, the world's first novel cocktail of 2 monoclonal antibodies in rabies post-exposure prophylaxis, and ZyCoV-D, the COVID-19 DNA plasmid vaccine. And of course, Zyvac MMR, which is the measles, mumps, and rubella vaccine. So on the board, you can see all our initiatives, the Zydus VCare initiative to improve immunization rates in India, all our brands, the Vaxiflu 4, Zyvac TCV, Twinrab, Vaxirab, and Zyvac MMR, followed by the educational initiatives, Fluxination, Typhoid Doesn't Discriminate, and the Viram initiative to put a full stop on rabies. Just before I close it, I would like to update all of you that Vaxiflu 4, India's first quadrivalent influenza vaccine, is now available in a 25G with a 25G Terumo needle. The advantages, it is recommended across all age groups, the freedom of use of any other gauge of needle as per your convenience, and it can be given not only to all age groups with assured needle sharpness, but also reduced possibility of breakage. So I thank all of you. And now, before I begin introducing you all to the esteemed speaker, more on what we were discussing about the World Cancer Week. As you know, colleagues, that cancer patients, particularly those undergoing treatment such as chemo or immunotherapy, have compromised immune systems, making them more vulnerable to infections. Influenza, with its potential to cause severe complications, can pose a substantial risk to individuals battling cancer. This is why the flu vaccine has become a critical aspect of patient care in oncology. So, on that note, I will like to introduce you all to our esteemed speaker, Dr. Nitin Shah Sir, who is the section head pediatrics at PD Hinduja Hospital, honorary pediatric hematologist, oncologist at BJ Wadia Hospital, Mumbai, a visiting pediatric hematologist and oncologist at Apollo Hospital, Mumbai, has been the past president of the Indian Academy of Pediatrics in 2006, fellow of IAP and ISHTM, chairperson IAP PHO chapter 2015-16, and editor of several books. As you can see on the screen, has delivered more than 2,000 guest lectures and orations and published more than 100 articles in various journals and books. So over to you, sir. Thank you so much.
Thank you, Trambak, for this wonderful introduction, and all the viewers, good afternoon on a very busy Sunday. Thank you for taking out time to learn something about influenza in oncology. Being a pediatrician primarily and then practicing pediatric hematology oncology and being in the field of vaccinology, I think I will probably do justice to convince you as to why you should use influenza vaccine more vigorously in your day-to-day practice. Not only for everyone, but also especially for those who are at risk, including the people who are having cancers. So let me share my slides and start my presentation. I hope you are able to see my slides. Right. So,
Yes, sir, it is visible.
in the next 30 minutes, I will take you to the journey of influenza prevention in onco patients. And before I do that, my disclosures that I work for most of the vaccine manufacturer, including Zydus, which are the sponsors for today's meeting. Influenza is often confused as common cold, but as we all know, common cold is really common and benign, whereas influenza not necessarily is always benign. It is caused by a single-stranded negative sense RNA virus from the orthomyxo virus family. And the fact that influenza becomes so troublesome is because it is hypermutable. And because of its hypermutability, every now and then the virus keeps on mutating. So if there are minor antigenic changes that happens from months to years, it leads to what we call antigenic drift, which lead to outbreaks all over the world. And that's also the reason why vaccines need to be updated based on the circulating virus strain, based on their antigenic makeup. And when there's a major antigenic shift, then that is known as a pandemic. And typically we had the pandemic in 2009, what was known as the PH1N1, or someone used to call it swine flu, etc., which started in Mexico and the epicenter being in Pune. It occurs where animals get to infect humans, and that's why you will see a lot of influenza happens where not only it's human but also reassorted with the animal or the bird strain. Now there are three influenza viruses which are important from the point of view of humans. Two of them are type A, mainly H1N1, and now what is circulating is the pandemic H1N1, which started in 2009, also known as PH1N1, and we have H3N2. And we used to have two types, Victoria and Yamagata, of which Yamagata is now not circulating since last 3 or 4 years. So the WHO has now said that instead of a quadrivalent vaccine, which contains H1N1, H3N2, plus both type B Victoria Yamagata, maybe the southern vaccine, which will come in the month of, the northern vaccine, which will come in the month of next August, September, maybe only a trivalent vaccine having only H1N1, H3N2, and the Victoria type B. Now, there is a type C virus, which is not important for humans because it rarely causes human disease. Now, this was the 2009 pandemic where we were all busy till midnight seeing patients, and it was panic all over the world and including in the country. And paper cutting make people even more worried. And these are the types of influenza ward which were made that time. I mean, of course, after that, COVID was even worse, where we had to use a PPE, but we were already using this PPE when we were tackling the patients with influenza. And in 2023, after the COVID went, during COVID time, of course, the influenza season was zero. There was no influenza season world over because not because COVID did something about influenza, but because people were using masks, they were not mingling with one another. There was a virtual standstill of the entire life, and people are not traveling, and there were huge use of sanitizers. So the influenza disappeared. And moment the lockdown was lifted, COVID disappeared, people started back to their normal life. There occurred massive outbreaks after the COVID of also flu and other respiratory infections like the RSV and so on and so forth. So we have had this type of again outcry in the media. Now, this is the latest season as far as the influenza is concerned globally. So you can see here from July 22, after the COVID disappeared, there have been these major peaks in the world, which typically happen in the cold countries during winter time. And in the country like ours, Australia, what we call the southern hemisphere countries, there occur two peaks. The major peak being pre-monsoon in the months of June, July, August, and a small peak in the winter, especially in the northern part of the country, like say Kashmir or New Delhi. So you can see the 2025 season has already started in the Western world, and you can see there's a huge outbreak, a tall number of patients as much as they were there in the previous 2 years. Now, these different colors show you different influenza type which are circulating, and you can see majority of them are either H3N2 or PH1N1 or unclassifiable H1N1, but just concentrate on the type B. So you can see type B Victoria is little darkish yellow color, and type B Yamagata is a lightish yellow color. And you can see here there is absolutely no light yellow color since last 2-3 years. It's all dark yellow color, which tells you that it is a Victoria or a lineage not identified type B. And that's the reason why from the northern vaccine of the next year, WHO is recommended to remove Yamagata as a strain. And talking about India, you can see here, this is the peak of India since 2022. Again, we can see the peaks have happened. And as I was saying, you typically have two peaks, winter and as well as monsoon, depending on which part of the country you are. And you can see our small winter peak in the months of now November, December, January has already started. After a huge monsoon peak somewhere in July, August, it came down, and now the winter peak is starting. And I'm sure after this, the peak will become little less till the next 2-3 months. And moment May, June comes, you will have again an outbreak of the southern type of influenza season. And again, if you see type B Yamagata, you can hardly see circulating at all. They're all dark yellow, which are all either unidentified type B or the Victoria type B. And that's the reason why Yamagata is not there. So maybe we will have only a trivalent vaccine and not a quadrivalent vaccine somewhere in the next year. Now coming to our topic as to after discussing the influenza season is the influenza disease burden. So you can see in general 1 billion cases of influenza are known to occur every year in the world. Now if you have 8 billion people and if 1 billion get infected, that means 1 in 8. So almost like 12 to 13% of the population gets influenza every year, and that's a huge disease burden. And that leads to 3.5 million cases which are severe, and no matter what you do, around 650,000 people die. And in adults, the attack rate is usually 5 to 10% during an outbreak, but in children, you can see it can be as high as 20 to 30%. So if you are practicing pediatrics or pediatric oncology, then you should be even more worried that your children patients are actually going to get more influenza than what adults get. And of course, in adults also, there's a huge disease burden because almost every 1 out of 10 people will get infected with influenza. And this all means a large disease burden, not only in the form of healthcare utilization, but also huge amount of money spent. Like it's estimated that almost $60 billion dollars are used every year globally to take care of people with influenza, either because they're absent or they are not, parents are absent because children are at home or they are hospitalized and so on and so forth. So you can see this is the what do you call meta-analysis of 34 randomized controlled trial contributing to 47 different influenza season right from 1970 to 2009. So a huge representing data which are PCR and or culture proven, and you can see these are the attack rates. So of course the attack rates, as we said, are more in children. Like say for all influenza is 15% versus 3.5% adult. For influenza A is 12 versus 2 and influenza B is 5.5 versus zero point 0.5. But because the adult population is so large in the world, there will be a lot of adults who will get infected. And unvaccinated children have considerably higher exposure risk than adults as far as influenza A and influenza B is concerned. And typically, influenza is a disease of in children of preschooler and school children. And in adults, it is usually the elderly or those who are at risk, like diabetic, obese, or patient with cancer survival, transplant survivor, chemotherapy, patients who are on biologicals, and so on and so forth, and chronic renal failure, HIV infected people, etc. So these are the people who are at more risk to develop severe influenza disease. So that's exactly what is shown here, that if you see the influenza disease burden, then first 5 years is a high disease burden of life, but look at above 65 years is so high, 96 to almost 100 per 100,000. That's like 1 per 1,000 people get infected with influenza every year. So you can see here these are the number of hospitalization which are calculated to happen in United States alone. 50 to 70% of the hospitalization occur in people who are above the age of 65 years, and in Brazil that could be as high as 30%. So again, there's a huge disease burden both in children and in adults. And if you look at the substantial mortality, then this is you can see here the mortality is seen in below 5 years, 65 or below 65 to 75 and above 75. And you can see here, no matter which country you look at, there is huge disease mortality burden of influenza. And these green bars are especially for India. And you can see here whether it's children below 5 years, adults, elderly, or very elderly people, they are actually among the top 5 countries. In fact, one of the toppest country in the top 5 countries having the mortality burden because of influenza every year. Now, if the disease burden is so high in general population, how can you spare patients who are suffering from cancer? So if you look at, first of all, why we should worry about influenza, because it can lead to serious complication. So it can lead to laryngotracheobronchitis, it can lead to myocarditis, Guillain-Barré syndrome like picture, encephalitis, common respiratory infection, pneumonia, bronchitis, otitis, etc. And if you look at the people who are at risk for the serious complication or even death, then older patient above 65 years, pregnant women, of course, children in the first 5 years, of course, and people living with immunosuppressive conditions. So that includes HIV, malignancy, stem cell transplant, organ transplant, and those who are on chemotherapy or high dose steroid, etc. It also includes people with chronic medical conditions. So like people with chronic cardiac, respiratory, pulmonary, renal, metabolic, neurological condition, liver disorder, hematological disorder, sickle cell disease, etc. So you can see here that this type of chronic medical conditions are as such generally seen in people who are little elderly above the age of 65 years in the Western country. I would say in our country, even between 50 and 65 years, you see a lot of people having one or two of these morbid conditions. And you can see here that above 65 years, of course, there are very high chances that the person has not one but more than one such comorbid condition, and that will make the person at high risk for influenza, severe disease, and mortality. So when a child with or an adult with cancer gets influenza, there are devastating effect. One is, as I said, oncology patients are at higher risk of influenza and its complication. Number two, oncology patients are at higher risk for hospitalization and death. Thirdly, when influenza happens, it can lead to significant neutropenia, especially if the patient is on a high-risk chemotherapy block. And that can lead to interruption in chemotherapy because you will not be able to continue chemotherapy till neutrophil count recovers, and that might take several days to weeks. And we don't know such interruption in chemotherapy, what is the long-term implication. And of course, when the patient of oncology gets hospitalized because of influenza, there are escalating costs. So I imagine a typical, let's say, a child with leukemia or an adult with leukemia getting influenza during the intense phase. and getting hospitalized, may enter into ICU, may go into a ventilator, and so on and so forth. So first of all, the person may not survive, and if he survives, he will end up spending few lakhs of rupees at least, as compared to cost of the vaccination, which will be around few thousand rupees for the doses that he requires. So it completely makes sense that if you can prevent a disease like influenza in oncology patient, you must always do it. All right. Now, if you look at the pneumonia incidence, the odds ratio, it is significantly higher risk for individual with comorbidity. So you can see pneumonia odd ratio is 1.5, hospital admission is 3.4, admission to ICU is 1.7, and death is 2 times more common than people who don't have comorbidity. And even immunocompromised individuals, the risk is even higher. The odds ratio comes as high as 3.8 to 4. And all influenza related cause mortality has been observed in individuals living with HIV, which is another important immunodeficiency which can happen. And again, you can see it, the odds ratio as 4. So malignancy patients or immunocompromised patients have as high as 4 times more chance of mortality than a person who is otherwise healthy adult. So whether influenza, I mean, are there any studies to say influenza happens more commonly in cancer patient and leads to more severe disease? So this is a study paper which has come way back in 1990, where they took cancer patient and they took 73 patients versus sibling control, or 55 community control which were there in the same vicinity. So to see cancer patient versus healthy contact versus healthy people around, and they followed up them for 2 seasons of influenza. And you can see the incidence of influenza in patients who have cancer was as high as 32%, whereas that in the control was 14%. So it's almost like 3-4 higher in patients with cancer than without cancer. Severity, duration, and complication though was similar, but hospitalization was definitely much higher in patients who had cancer as compared to those who didn't have cancer. And of course, there was interruption of chemotherapy in at least 2 to 3 out of the 73 patients. You can see almost 5% of the patient who develop influenza will have enough neutropenia to lead to interrupted chemotherapy. And other thing is they may not be as well protected by the level of antibody which are otherwise protective in a normal person. So again, you need to give annual influenza vaccine so that you have maintained antibody level so that they don't land up into trouble. Now, there are other studies which have also looked at the severity of influenza in cancer patient, and they have all shown either they have double the time for recovery, including hospitalization. 80% of the patient with influenza during cancer therapy have interrupted chemotherapy, and influenza can become a niche in the respiratory system for invasive bacterial disease like either pneumococcal or a staphylococcal sepsis, and all in all, this all leads to increased mortality. So how do you prevent influenza? And during COVID time, it has taught us how to prevent respiratory infections in general. And we have regular hand washing, avoiding close contact with sick people, wearing a mask, especially a proper fitting mask, avoiding touching one's eyes, nose, and mouth after you have met people or shaken hand with them, covering mouth and nose while coughing, early isolation, self-isolation when you are sick so that you don't infect others in the community. And this is very true for the nurses and the physicians who take care of oncology patients. The moment they are sick, they should actually wear a good fitting N95 mask and not touch the patient. And if they're sick enough, then they should actually not enter the oncology ward so that they don't infect inadvertently an onco patient. And when you use all this material, you correctly dispose it so that there is no chance of cross contamination, and a good ventilation house or a good ventilated hospital is a requirement. Now, these are all proven ways of preventing influenza, but these are not as easy to continue to be followed up. Like we saw in COVID, there was such a fatigue in wearing mask, a fatigue in doing hand washing, a fatigue in having social contact prevention, etc. Because we are animal. We are a social animal, and we like to meet people. So the what is the other way is to vaccinate against influenza, and let's talk about influenza vaccine and how it helps in general and in cancer patient. So you can see here, when you are given influenza seasonal vaccine time to time, there are several benefits. It helps reduce influenza transmission overall. So if a huge percentage of eligible people are vaccinated against influenza, then you will have blunting of the season. It helps prevent severe disease and deaths. This is especially true for people who are at risk of severe disease like immunocompromised patient or patient with severe comorbidities or metabolic disorder. It protects those high risk population, especially from getting severe disease and hospitalization. It helps reduce absenteeism for people who are at work, and for absenteeism for parents whose children fall sick. So these are what you call indirect or societal benefits of giving influenza vaccine in general population. So it is estimated that, like say in United States, in United States, the recommendation is to give annual influenza vaccine to anyone who's above the age of 6 months. So every person who's above 6 months actually should receive. Not that everyone does receive, but that's the recommendation. And if this is followed, then it was calculated that during 2018-19 influenza, vaccination actually prevented 4.4 million influenza-related illness, 2.3 million medical visits, around 60,000 hospitalization, and around 3,500 deaths. So this is the power of a single vaccine which can prevent so much of morbidity and a potential mortality. So annual vaccination, the benefit is it lowers the odds of hospitalization, which is essentially because of pneumonia. But remember, when you get influenza in a patient with comorbidity, it can precipitate either a heart failure or a coronary artery disease. So this also, if the influenza is prevented, will also indirectly prevent this complication. So there is a 40% reduction of hospitalization with influenza during pregnancy. Pregnancy is a immunocompromising condition. So it also tells you that a disease, or not a disease, but a condition as much like a pregnancy, which can be immunocompromising, you can benefit by taking vaccine. So 75% of the is the vaccine efficacy against life-threatening influenza in children, and 60% against the non-life-threatening influenza in children. So you can see, if you have taken vaccine, then 60 to 75% chances are there that you will have less incidence of morbidity and mortality. And the indirect benefit of influenza, of course, is by preventing influenza, you prevent metabolic complication and cardiovascular and respiratory complication in people who have this type of comorbidities. So this is what we say. If you have given influenza to child, there are 75% reduction in severe flu-like lower respiratory infection, 40% fewer hospitalization, 50% fewer OPD visits. When they don't fall sick, there is one-third reduction in the antibiotic prescription, because as you know, in flu, a lot of people are prescribed antibiotic. 77% is the parental absenteeism is reduced, and 50% decrease in the school absenteeism. So all this leads to direct and indirect benefit to the community. And if you prevent influenza in children, they are the one who spread the disease in the community. Even the adults will benefit. So like pneumococcal disease, where you have massive cover of pneumococcal vaccine, conjugate pneumococcal vaccine in the childhood population, for one child who benefits out of vaccine, two people don't get invasive pneumococcal disease in the community as a part of herd effect. Same thing happens with influenza, that you will immunize children and your disease disappears even for the adults. So vaccinate the patient once in the maintenance therapy. During the acute intense therapy, especially multi-drug chemotherapy, typically like say in a leukemia or a lymphoma person, the vaccine may not work. Of course, it being a non-live vaccine, it's like a killed vaccine, it is safe, but may not work. So you will wait till maintenance phase starts, where the immunosuppression is less common, unlike the intense phase, and then you continue vaccination annually forever. Remember, it is not enough to just give them during chemotherapy, or once you stop the chemotherapy, you have to continue, because immunosuppression, especially for patients like Hodgkin disease, solid organ transplant patients who are on lifelong immunosuppression, there is always an increased risk of influenza related disease and mortality throughout. So you have to continue annual vaccination in these onco patients. Immunize the caretakers, because a child or an adult with cancer is in contact with either healthcare personnel. So that's where the healthcare personnel and the nurses have to take the vaccine if they're working in the onco ward, and the caretaker at home. So their siblings, their parents, etc., contacts who are frequently coming home, they also should be given vaccine so that they don't transmit influenza to the cancer patient. And there is never a best time. The best time to immunize is at the first contact. So moment you are in contact with a cancer patient, you should immunize with the vaccine that is available, and don't wait for the season to start or season to end. And this is the most important message I want to give you. If you are a healthcare worker, not only taking vaccine will benefit you if you are elderly like me, or if you have diabetes or blood pressure or something, but you will not get influenza, you will not transmit it to your patients. So especially those who are working in ICU, those working in onco ward, must see to it that they take annual vaccine. So this is not only for doctors and nurses, but every other person who is in the hospital, who is going to enter the onco ward, the transplant ward, and touching the patient or be in contact with the patient. So that's why I've said it includes both you and me as well. Now, whether the vaccine will work, so this is a study done way back. This was a study to see whether the what is the seroconversion rate, what are the titers in children with cancer. So this is like you can see acute lymphoblastic leukemia is where we use most immunosuppressive therapy during the induction and in the maintenance therapy, and it's a long therapy in children. So this was studied when the trivalent vaccine was in use. So they gave these children vaccine. They studied the pre-vaccination antibody conversion and titers, and they follow up the children at 3 weeks after the vaccine, where you'll have the maximum response, and at 6 months. And you can see here that for all the three strain, H1N1, H3N2, and type B, the pre-vaccination, compare that with the post-vaccination. Of course, I mean, either children received vaccine or they received control. I mean, they didn't receive vaccine, so they were compared with the control. So you can see here, pre-vaccination, H1N1, you can see there was hardly anyone who had contact with H1N1, and post-vaccination, you can say 3 weeks, 35% children seroconverted, and 6 months, 45%, whereas hardly anyone seroconverted in the control arm. Same way for H3 and 2, you can see here there were more people who are converted if they took the vaccine, like say 78% at 6 months for H3 and 2 compared to only 17% with the control. And same way you can see type B, 88% versus 47%. So vaccine works when you give it even during the cancer therapy. And of course, you can see these are the titers and fourfold rise and different ways of looking titers. For all of them, you can see here overall at 6 months, the titers were much higher and much more meaningful in patients who had cancer who are given vaccine compared to those who are not given the vaccine. So this is the data to say that vaccines, influenza vaccine works even when you give it to a cancer patient with little subnormal immune response otherwise expected because of the chemoradiotherapy. And this is a multicentenary prospective observation study which is published in 2023. This is a very latest study. So what they did was this original study enrolled patients with advanced solid tumors receiving a X protocol in the Italian protocol right from 2019 to 2020. And of the 1188, almost 1,000 plus people who are evaluable, they looked at what happens if they've taken the vaccine and what are the odds ratio of either developing complication, etc. So you can see at median follow-up 20 months, influenza vaccination demonstrated a favorable impact on the outcome receiving the IC protocol in terms of median overall survival, which was 27 months versus in vaccinated versus 20.9 in non-vaccinated, with the p value being highly significant. Median progression-free survival was 12.5 versus 9.3. Again, P was highly significant, and disease control rate was 74.7 versus 66.5, again statistically significant. And in the multivariate analysis, there could be several factors for this type of outcome. Influenza vaccination turned out to be a favorable factor with an odds ratio or a hazard ratio of 0.75, again, which was statistically significant. So it means that when you give this vaccine, as shown in the study done in children, that there is good immunogenicity, but not only that, there is also a better outcome of the disease because maybe because they don't die of influenza or because there is no interruption in the chemotherapy if they've taken influenza vaccine in time. Now, when do you immunize? Once intense therapy is over, as I said, during maintenance in a leukemic child, you can do. In a child who is, if you have not started before, then 3 to 6 months after chemotherapy is over is the best time because that time the immune system will bounce back. In a transplant patient, it happens at 6 months. So you don't give live vaccine till 2 years, but you can start killed vaccine like influenza as early as 6 months. And ideally 2 weeks before solid organ transplant, if there's nothing urgent about it, or post solid organ transplant when your immunosuppression has been reduced to a minimum level. And don't forget, contacts of all these patients should be immunized as soon as possible. Continue immunization in the patient and in the context annually till the time the patient is immunocompromised. And live attenuated intranasal vaccine, which is available internationally and also in our country through Serum Institute of India, through my lab laboratory, it is contraindicated in immunocompromised patients, including cancer patients. So what you should use only the killed injectable vaccine and not the intranasal vaccine. So you get two types of vaccine, the northern hemisphere vaccine and the southern hemisphere vaccine. The northern hemisphere vaccine comes somewhere in August, September to cover the winter peak in November, December, January. And the southern vaccine comes somewhere in March or April to cover the monsoon peak, which happens between June, July, August. So you can see in our country, most of part of the country behave like a southern hemisphere where the peak is during monsoon. So use the vaccine which comes preferentially now, which will come maybe in March, April, like, and that to cover the monsoon peak. But there are two areas: the extreme north, Srinagar, and to some extent Delhi, and the extreme south, where the monsoon is late, like Chennai and Vellore. You see, the season is somewhere in October, December. So you will use a northern type of hemisphere vaccine in these parts of the country. But otherwise, most of the part of the country, you will use a southern hemisphere vaccine, which comes somewhere in March or April. But remember, if you have a cancer patient which is coming out of this season, don't wait for the next vaccine. Give whatever is available. So the first time you give whatever is available, and next time onwards you can shift him to the southern type of vaccine at earliest possible contact. All right. So, what are the recommendations by different bodies? This is the last part of my talk. WHO recommends that 6 months to 8-year-old aged children should be given the vaccine routinely. After 9 years and in healthy adults, annual vaccination is recommended, one dose. Older adults, high dose recommended adjuvant vaccine which are available should be given because the normal vaccine may not work. And in high risk groups, that would include our onco patient, you give only injectable vaccine, and it should be given to all those with comorbidities and including those who are suffering from cancer or transplant survivors. And this is the Indian Academy of Pediatrics. This is a very busy because we give a lot of vaccine to normal children, but just to look at the influenza, and you can see it says that influenza should be offered from 6 months of age onwards and should be given till 5 years to all children. But for those who are high risk, that will include cancer survivor, the influenza vaccination should be continued till 18 years and beyond. Now, because we see up to 18 years, we cannot say about adult, but it says that 18 years and beyond. So, which means influenza vaccine for cancer patients should be continued almost lifetime. And this is the CDC guideline, which says they prioritize for flu vaccination during a vaccine shortage, which will include patients with comorbidity and patients who are immunocompromised, including immunodeficiency and cancer patient. And lastly, this is the ASCO guideline, which has the influenza at the top. It says for all ages, annual vaccination should be. So this is recommendation specifically for immunization for adults with cancer by the ASCO guidelines. So what is the role of all of us as healthcare physician? So you can see here, if you look at the top 10 reasons why an adult has not received influenza vaccine, say in United States, and I'm sure this is applicable to all parts of the world, 52% feel that they will not fall sick. 40% feel they never get influenza. Another 40% said they are not at high risk. They may not know that they may be suffering from diabetes. 30% say they are worried about side effect. And in fact, there are no side effects. These are all myths. Another one third feel that getting influenza is better than getting vaccine. That's completely rubbish because influenza can be very serious and severe and can lead to death. They do not think influenza vaccines work well. That's again not true. As I said, for a severe influenza-like illness which leads to hospitalization, the vaccine efficacy is as high as 80 to 85%. Then some lame XU did not have time, did not have trust, do not like needles, do not like the cost, etc. But you can see, so these are the reasons where we can pitch in by giving them the correct advice that influenza can be serious, influenza can happen even in a normal person, influenza is more severe in people who are at risk, the side effects are very few as compared to the bad effects of disease, and the vaccine is not that expensive and it is easily available, and it is not painful. So I think we should break these 10 myths which are prevailing in the community. And what are the strategies? So enhance the access, so home visits, reducing out-of-pocket costs, vaccination program in school, co-administration at the when the patient come for other vaccine, give influenza vaccine also together, increasing awareness by all the measures that I spoke in the previous slide, intervention. So you should have immunization information system. You can have a SMS to this patient that you are due for influenza vaccine, etc. And all these type of reminders ultimately will help you to improve the vaccination coverage of influenza in patients who are at high risk, including our cancer patient. So this is 1947 New York Times photograph where people are being to get the influenza vaccine because huge outbreak of influenza had happened. And this is something which we will love to see for our onco patient where they also come forward and take the vaccine. So I always say that get flu shots and smile rather than getting flu and crying, because flu can be severe and serious and can lead to mortality. So uh, flu ends with you. So unless me and you mean healthcare worker, are not convinced about use of influenza vaccine in general and in immunocompromised patient, including cancer patient in particular, we will be not doing the proper service to the nation. Well, I thank you very much for your patient hearing, and I hand over mic back to the organizers. Thank you.
Thank you so much, sir, for your enlightening session on the topic. I am sure with your expert insights and by prioritizing the flu vaccinations, we are empowering the cancer patients to stay stronger, continue their treatments uninterrupted, and ultimately improve their quality of life. So now I shall be taking up the questions from the
Mhm,
audience and I shall
mhm,
relay to you, sir.
mhm, mhm.
So we'll take the first question, which
Yes, please.
says that is it recommended to give the flu vaccine at different times during a patient's cancer treatment cycle, or is a specific window more beneficial?
Correct. So you would probably not give in when you're giving a multi drug intense induction chemotherapy because it may not work. So that time other measures like mask, sanitization, coughing etiquette, and not mingling with crowd, etc., would be important. Moment your immunosuppression is little lesser, you should start influenza vaccine. And as I said, there is enough data to suggest that when you start influenza vaccine, say during maintenance phase of a leukemic child or a leukemic patient, it works well. So that is the time when you start and then you continue it every year.
Thank you, sir. The next question is, can cancer patients still experience significant side effects from the flu vaccine, and how should these be managed?
Correct. So the common side effects of flu vaccine are local, especially little pain and little fever. So they are like not grade 3, which can be incapacitating. They are mild and they are most of the time self-resolving or respond very well to paracetamol. I imagine in United States, every child, every person above 6 months of age taking the vaccine, even if it's a 60% is the coverage, how many people take and what happens to them? Nothing. So unlike many other vaccine which can be like say zoster vaccine, one of the most reactogenic vaccine in adult, or a wholesale based pertussis vaccine in children, which can lead to high fever, etc. in 40%, as compared to flu vaccine, absolutely no side effects. So you should really not worry about the flu side effect. And cancer patients are no different from general population. Their side effect profiles are as same as the general population.
Thank you, sir, for your insights. The next question is, when is the ideal time for oncology patients to receive their annual flu vaccine, particularly in relation to the timing of their cancer treatments?
Correct. So as I said, during cancer treatment, the ideal time is when the immunosuppression is going to be minimal. So in a leukemic child, it will be like during the maintenance phase. Again, in a lymphoma patient, once your intense induction is over, in a solid organ transplant, maybe before the transplant, if the transplant can wait 2 weeks before, or when you reduce your suppression post-transplant. And in a stem cell transplant, that is bone marrow transplant, you give 3 to 6 months after the successful transplant and patient not being on very severe immunosuppression for graft versus host disease. So these are the right time when you will start. And of course, it's not just the beginning, it has to be continued annually.
Yes. Thank you, sir. The next question is, how does a flu vaccination reduce the likelihood of complications that could lead to hospitalization or intensive care for cancer patients?
Correct. So influenza can itself lead to a primary viral pneumonia. More often than not, it also leads to secondary bacterial pneumonia, like either with pneumococcus or staphylococcus. This is true for general population, more so true for immunocompromised, including cancer patients. This was so amply proved in the 1918-1919 Great Asian Flu, where the American soldiers who were in barracks, there was a massive outbreak of influenza. So there used to be a wave of influenza, followed after 2 weeks with a wave of pneumonia and death. And they did post-mortem cardiac sampling of the blood for culture. And to their surprise, those who had died, they grew either staphylococcus or pneumococcus. So they very well established in 1918, 1919. We're talking about more than 100 years back, that there is a primary viral infection. They recover, some of them don't recover, they get into secondary bacterial infection, and then they succumb to either pneumococcus or staphylococcus. So if you have taken a primary viral vaccine like influenza, and also say conjugate pneumococcal vaccine that you should give to all adults, then probably this adult will not get into trouble, especially if that adult is immunocompromised like diabetic, metabolic disorder, or a cancer patient or a transplant survivor. So that's the reason why it will prevent hospitalization by preventing this type of a cascade play between a virus and a bacteria. And of course, those with comorbidities, and it's not that only normal people have comorbidity, even cancer patient can be comorbidity. So lymphoma patient can be diabetes and obese. So he's even at more worse high risk for all types of problem. And the cancer may remain on the side, and he may develop a coronary artery disease or a myocardial infarct because of the influenza, which tips the balance. So giving vaccination has both direct benefit of preventing viral pneumonia, direct benefit of preventing secondary bacterial infection, and indirect benefit of preventing worsening of the baseline metabolic high risk disease that they may have along with the cancer.
Thank you, sir. The next question is, what impact could higher flu vaccination rates in cancer patients have on overall survival rates
So I
of the
showed you the
patients?
latest data in 2023, which looked
Yes.
at more than 1,000 eligible people. They
Yeah.
looked at the odds ratio of disease-free survival, overall survival. It all favored vaccinated versus non-vaccinated cancer patient. And when they did multivariate analysis, the single factor that came out independently in favor was influenza vaccine. So I think very recent 2023 data is very eye-opening, and it goes on to prove what was already known, that if you have taken the vaccine, it will not only prevent mortality and morbidity because of the disease influenza, but also because of lack of less interruption of the chemotherapy, it will improve your overall survival.
And sir, we end with one final question. Any guidance for stem cell transplant children in specific for the
Correct.
influenza
So stem
vaccination?
cell transplant patients usually are heavily immunocompromised post-transplant. Most of them will be on some graft versus host disease immunosuppression, and they will not respond to any vaccine. So while killed vaccine given that time will be safe, but they will not be effective. Of course, giving live vaccine during that time will be hazardous because it can lead to a live vaccine virus-induced disease. So generally, the once the engraftment is good, say on day 28, day 15, whatever, depends on how successful it is, and your immunosuppression you are able to bring down because there is no major GVHD. By 6 months, they are good enough in a immune bounce back to respond to killed vaccine, and safety is established. So you start your influenza vaccine at 6 months. And for if you are still on severe GVHD and a very heavy immunosuppression, then you will wait for the till the immunosuppression is brought down. And for live vaccine, of course, we are talking only influenza today, but live vaccine like MMR, chickenpox, etc., would be given only 2 years after the successful engraftment and the patient is of any immunosuppressant.
Thank you so much, sir, for your expert insights and taking up all the queries. I thank all the audience for joining us this evening, and a warm thank you from Zydus Life Sciences. Thank you so much, everyone.
Thank you. It was pleasure meeting all of you. Thank you.